السلام عليكم ورحمة الله. مرحبتين بكم جميعا our participants. اليوم إن شاء الله راح تتكلم بروفيسور نهال الشقنقيري، بروفيسور أوفثالمولوجي at University of Alexandria. بارك الله وفعل على تلبية الدعوة، وإن شاء الله يكون في ميزان حسناتها. راح تتكلم اليوم على tips in congenital cataract surgery. تفضلي دكتورة نهال.
بسم الله الرحمن الرحيم. Ramadan Kareem. It's a pleasure and honor for me to participate in your meeting, and I will speak about tips in congenital cataract surgery. When you go for cataract surgery with IOL implantation, in these children, you should go for anterior capsulorhexis exactly 5 millimeter, posterior capsulorhexis 4 millimeter, combined with anterior vitrectomy, and as you see, the IOL should be implanted like that inside the capsular bag. Here, another case, this is a 5 and a 4 millimeter. Another case, 5 and 4 millimeter. Why? When we go for anterior capsulorhexis like this, it should be 5. Why? In order to cover the IOL optic, because the IOL optic is 6 millimeter, to cover it inside the capsular bag. Smaller than 5 millimeter, capsular phimosis will occur, and you will need to go for secondary surgical intervention. How to perform anterior capsulorhexis? If you have a total cataract like that, and to start surgery, start by the MVR knife by the side port first. And then you inject viscoelastic. You go at 3 o'clock and then inject, and gradually you go backward. Then the second MVR knife, the second side port, and finally the keratome, which is 3 millimeter. When you go this, you will ensure that the pupil will stay dilated. If you go first with the keratome, sudden collapse of the anterior chamber may cause constriction of the pupil. Secondary, we go for trypan blue stain to stain the anterior capsule. And then we can go with the rhexis forceps to perform the 5 millimeter anterior capsulorhexis. This will ensure that it will cover the IOL optic, which is 6 millimeter. Sometimes you can use the morphology of the cataract as a guideline for the anterior capsulorhexis, as a landmark. Usually the lamellar cataract is 5 millimeter in diameter. So you can use the micro rhexis forceps, and I prefer the 25 gauge rhexis forceps. It's a small one. And then we will follow the edge of the lamellar opacity. This will be the exact 5 millimeter rhexis, and we will cover the IOL. Here, another case. This is the 5 millimeter. It will cover the IOL. Now look here. Where is the landmark of anterior rhexis? Is it that one, or the dark area, or this area? This will be the landmark of anterior capsulorhexis. Here it will be ideal and cover the intraocular lens after surgery. The second step is hydrodissection. It is very important. You go with a cannula just underneath the anterior capsulorhexis, anterior the capsule, and then you elevate the anterior capsule and inject. Secondly is the hydrodissection. You go into the substance of the cortex, and then you aspirate the lens. Hydrodissection and hydrodelineation will facilitate the irrigation aspiration. It's going to be very easy. It ensures complete cortical cleanup in order to prevent secondary cataract. But take care never to proceed with hydrodissection if you see this. This is a child with bilateral cataract. This is a total cataract. And what is this? This is a posterior capsular defect. So we should not go for hydrodissection in these cases. This is another child. Look to the morphology of cataract here. This is actually a posterior, congenital posterior capsular defect. Another case, this is what here with magnification, this is a congenital posterior capsular defect. It is very common to see congenital posterior capsular defect. Here, this is the elliptical posterior capsular defect. Sometimes it is seen against red reflex. Here, another case of posterior capsular defect. It's a triangular defect, a circular defect. Here, even the cortex is behind the posterior capsular defect. Here a circular defect, here a circular defect, and you can see here calcification of the anterior vitreous face. And sometimes the posterior capsular defect is hidden behind a total cataract. So you have to look to the morphology before proceeding with surgery. You think it's a total cataract, but actually, can you see here the edges? This coincide with the posterior capsular defect. Some cases of polar opacity may hide a small posterior capsular defect. So what the important tip here is that when you proceed with congenital cataract surgery, please look to the morphology of the cataract before proceeding with surgery. Here, with high magnification, and then focus on the posterior capsule. What is this? This is a congenital posterior capsular defect, so we will not go for hydrodissection or hydrodelineation. The next step is polishing the back surface of the anterior capsule. Very important after irrigation aspiration to clean the anterior capsule like that from lens epithelial cells. It should be crystal clear like this. If we don't polish and leave like that the anterior capsule, what's going to happen? After surgery, despite being a beautiful surgery, after surgery, there will be extensive fibrosis of the anterior capsule. And this will prevent good visualization of retinal exam if needed in the future. And if we don't polish, despite having a beautiful surgery along years, this is the anterior rexus and posterior rexus, proliferation of the lens epithelial cells may occur over the anterior surface of the lens. Here, these are pearls coming from the back surface of the lens over the anterior surface of the lens, and sometimes in front and behind the IOL, necessitating secondary surgical intervention to clear the visual axis. The next step is posterior capsulorhexis. If we leave the posterior capsule intact like this, like adults, what's going to happen? Posterior capsule opacification will occur in 100% of cases. See the difference along years? This is bilateral case, one with posterior capsule opacification and another with clear visual axis because we did a posterior capsulorhexis and anterior vitrectomy. And sometimes YAG laser capsulotomy is not easy in children. It may lead to IOL pitting or IOL cracks, necessitating IOL exchange in the future. And sometimes the posterior capsule opacification in children is very dense, like this, and requires secondary surgical intervention. And sometimes children are not cooperative for YAG laser capsulotomy, that you have to go again behind the intraocular lens in order to clear the visual axis. So it is very important to proceed with posterior capsulorhexis. And the diameter should be 4 millimeter, not less than 4 millimeter. Why? Because if you go, this is the ideal posterior capsulorhexis size. If you go for smaller posterior capsulorhexis, capsular phimosis will occur, obstructing the visual axis, and you will have to go again for secondary surgery to clear the visual axis. How to perform posterior capsulorhexis? With the tip of the cystotome, don't go perpendicularly. You go for hooking, you just hook the posterior capsule, and then you tent it, you make it like a tent, and then you tear it. If you see a triangular tear, this is ideal. It means that you didn't open the anterior vitreous face. Here again, hooking, tenting, more tenting, and tearing into a triangular tear. And then through this tear, you injected viscoelastic. Very important step that the tip should be at the edge of the tear. It should not go into the vitreous. Outside here the tear, and you start to inject. You will see circular halo like this. It means that you are injecting in the right space between the posterior capsule and the anterior vitreous face, which is called Berger space. This will make the posterior capsulorhexis very easy. Here, another case with the cystotome parallel to the posterior capsule. You hook the posterior capsule, you tent, and then you tear. See, it starts here a triangular tear. Here, it's a triangular tear. Now you go in at the edge of the tear and you inject into the burger space. You can see here the circular edge of the viscoelastic into the burger space. This will make the posterior capsulorhexis very easy to perform a 4 millimeter posterior capsulorhexis. This is the ideal posterior capsulorhexis. Here again, don't go into the vitreous. Inject, and here the halo, the circular halo, and then the posterior capsulorhexis 4 millimeter. This will be ideal after IOL implantation, and this is how it appears. Next, the anterior vitrectomy. We should go for a very good anterior vitrectomy. We start first by dry vitrectomy, and then we introduce the irrigation aspiration. Why? In order to avoid overhydration of the vitreous. Why? Because if the vitreous overhydrates, can you see this kinking of the posterior capsulorhexis? This is a vitreous strand going towards the wind. I don't use any stain to see the vitreous. I don't use steroids to see the vitreous. How to proceed if you have a kinking like that and you have a vitreous strand? You go directly with a cutter, dry vitrectomy, just dry vitrectomy. Look here to the edge of the posterior rhexis until it becomes circular. If you see it circular like that, it means that you removed the vitreous strand coming outside to the wind. Another important issue that we go beyond the edge of the posterior capsulorhexis, not only in the middle. Why? And here after IOL implantation. Why? Because can you see these strands? Inadequate vitrectomy, lens epithelial cells will grow over remnants of the anterior vitreous face. Can you see here? These are remnants of anterior vitreous face. This is not a good vitrectomy. Despite a beautiful surgery, or you did anterior rhexis, posterior rhexis, but inadequate vitrectomy. Here, this is the IOL between the anterior and posterior rhexis, but years after surgery, extensive pearls growing over remnants of the anterior vitreous face like that, obstructing the visual axis. And in some cases, you have to go again behind the intraocular lens in order to clear the visual axis. But when you go for a very good anterior vitrectomy, lens epithelial cells will stop at the edge of posterior capsulorhexis, will respect the edge of posterior capsulorhexis perfectly like that. Here, by years passes by, can you see here 360 degrees, clear visual axis. This is extensive pearls, but respecting the edge of posterior capsulorhexis, nearly 180 degrees. And extensive here pearls, all respecting the visual axis. Can you see the pearls? 360 degrees, but with clear visual axis. Here the pearls extending 360 degrees with clear visual axis. And here, years after surgery, this is 5 years after surgery, very dense pearls, but with clear visual axis. Here, even if you have a small posterior capsulorhexis, but with good vitrectomy, you're going to have a clear visual axis. This is years after surgery with small posterior rhexis, but yet clear visual axis because vitrectomy was good. What about IOL implantation? We finished vitrectomy. After performing vitrectomy, we can inject a single piece inside the capsular bag between the two rhexes, or a multi-piece between the two rhexes. How? When you introduce the injector, look to the edge of the anterior rhexis. Focus on the edge of the anterior capsulorhexis. The lower haptic of the IOL should be just underneath the anterior capsulorhexis, and then inject the IOL. This will ensure that the IOL will not be injected into the vitreous through the posterior rhexis. Then easily, with a Y-shaped spatula, you can push the IOL inside the capsular bag. Here another case. Focus on the anterior axis, the lower haptic just underneath the anterior axis like that, and then inject the IOL, leave the IOL, go in with the spatula and push inside the capsular bag. The multi-piece, you can do the same thing. This is the lower haptic, just touching the underneath the anterior axis here, inject the IOL, and then push the IOL so that the lower here haptic and the haptic optic junction inside the capsular bag. And then comes the upper haptic. Go midway between the haptic optic junction and the edge of the haptic with a Y-shaped spatula. Push forward, but this haptic optic junction should be inside the capsular bag. Push forward, push until it is inside the capsular bag. Here, as you see, the multi-piece between the anterior and posterior rexes. This is before and at conclusion of surgery. Before and at conclusion of surgery. A triple lamellar before and at conclusion of surgery. You can easily implant it between the anterior and posterior rexes. This is before and after. This is before. The anterior rexes was a little bit larger, but it's still covering the IOL optic. Here, another case, the posterior rexes was a little bit larger than 4, but still it was possible to implant the IOL between the anterior and posterior capsular rexes. Let's see what happens years after surgery. Few months after surgery, you can see here the anterior and posterior rexes crystal clear. And then lens epithelial cells starts to grow from the periphery. This is a single piece, and this is a multi-piece intraocular lens. Lens epithelial cells comes from the periphery, and they go towards the center, like this 360 degrees along months and years, but clear visual axis. Can you see the pearls here? Extending 360 degrees and respecting the edge of posterior rexes. These are the pearls. These are years after surgery. Sometimes they go like that and they extend 360 degrees. They become denser and denser with time until proceeding like that, very dense pearls along the years, but with excellent clear visual axis. Sometimes colonies like this, and sometimes 4 areas or 4 spots, and sometimes diffuse pearls like this. And sometimes even years after surgery, we see calcification, but with clear visual axis. Can you see the whole capsular bag? This is 5 years after surgery. The whole capsular bag is calcified and pearls, but with perfect clear visual axis. Calcification all over, but with clear visual axis. This is 10 years after surgery, and the whole capsular bag is calcified with clear visual axis. And this is another eye 10 years after surgery. It is only fibrosis without pearls. So it is variable. Sometimes we see fibrosis only. And here 10 years after surgery, only fibrosis, but with clear visual axis. Sometimes we see only pearls. This is 10 years after surgery, and this is 20 years after surgery with extensive pearls, but with clear visual axis. And sometimes we see both fibrosis and pearls. Here, fibrosis and pearls, and even calcification of the capsular bag. See here, extensive pearls and calcification. This is 10 years after surgery. Some cases, the pearls may become diffuse and amalgamated like this. Diffuse. Can you see the cortex? تخيلوا if we left the posterior capsule intact, we would see this terrible picture in the center, but due to the presence of the posterior rexes and anterior vitrectomy, we maintained clear visual axis even after 10 years. Here with clear visual axis. This is a bilateral case 10 years after surgery with single piece and a multi-piece in the other eye. And this is another case 10 years after surgery, single and multi-piece with clear visual axis. And this is an eye 20 years after surgery, bilateral case. Can you see? Despite the extensive calcification, despite the extensive pearls, but actually we maintained clear visual access along 20 years of surgery. This is another 20 years after surgery. It's only fibrosis and calcifications of the submarine brain, but with beautiful, clear visual access. The advantage of this surgery, and when you choose the right intraocular lens, I have no financial interest whatsoever in anything, but I use Ecrisoft IOL along the past 25 years. When you do an ideal surgery, anterior and posterior capsulorhexis, and a good intraocular lens, it is very easy when myopic shift to occur in these children, you can rotate easily the intraocular lens into the anterior chamber, hold it and cut it into two pieces, get it outside, and you can inject another multi-piece IOL in sulcus. And here before and after IOL exchange for myopic shift. But when you go for inappropriate surgery, let's see, here, small eccentric anterior axis, no polishing, extensive fibrosis of the anterior capsule, secondary cataract, and then we had to go for clearing the visual axis, aspirating the pearls, and even the posterior axis was small and eccentric, and anterior vitrectomy was inadequate, and we had to clear the visual axis. So we have to go for appropriate surgery for these children. This is the first part of the talk. The second part is cataract surgery without IOL implantation. This is done in infants with congenital cataract below the age of 2 years with bilateral congenital cataract, where we go for cataract surgery and fit the babies with aphakic spectacles. How to proceed with cataract surgery in these babies? I prefer the anterior approach through 2 MVR knives, 20 gauge. That means that the wound is 0.9 millimeter. And then with a microrhexis forceps, it's 25 gauge rhexis forceps. I perform the anterior capsulorhexis, frequent regrasping, like this, and it should be 6 millimeters, and then hydrodissection, and then hydrodelineation, and then we go for irrigation aspiration. A very important step in congenital cataract is to proceed with polishing the back surface of the anterior capsule, and we're going to see why. This is 6 millimeter anterior rhexis. Then we proceed with 6 millimeter posterior rhexis combined with anterior vitrectomy. If we perform the surgery like that, what's going to happen? We will see. But I don't use trypan blue stain except if I have a total cataract like that. We use the trypan blue stain in order to facilitate the production of anterior capsulorhexis, desired size. We can use the morphology here of the congenital cataract. This is a 6 millimeter congenital cataract. So we can proceed and take the morphology of the congenital cataract as a landmark for 6 millimeter anterior capsulorhexis. But take care, not all the cases of congenital cataract are central like that, and we take it as a landmark for the anterior rhexis. Sometimes the lamellar cataract, as you see here, it is eccentric. So here, take care. The anterior rhexis should be central, and we should not take the congenital cataract as a landmark. As I said, the polishing is very important. And then we proceed with the posterior rhexis in the conventional way we said it before, hooking, tenting, and tearing into a triangular tear, injecting into burger space, and then proceeding. But here with a 6 millimeter posterior rhexis and not 4, combined with very good anterior vitrectomy. Why we go for 6 and 6? Because if we go for smaller anterior rhexis, like 5 and 4, what's going to happen? Few months after surgery, you're going to see this capsular phimosis, and severe capsular phimosis, you have to go again with secondary surgical intervention to cut the edge and to clear the visual axis. And you should not go for larger rhexis. it should not be larger than 6 millimeter. Why? Because at time of secondary IOL implantation, the capsular ring will retract. Can you see this is a retracted capsular support? Here it is retracted. It is very difficult to implant the secondary IOL over a retracted capsular support. And sometimes the IOL optic will be smaller than the capsular support. Can you see the capsular support here is larger than the IOL optic? And in some cases, when you come to implant secondary intraocular lens, see, it is very retracted capsular support, extremely retracted, that you cannot implant a secondary IOL in sulcus. So the ideal is 6 millimeter anterior rexus, 6 millimeter posterior rexus combined with good anterior vitrectomy, or in some cases you can go for 6 and 5 combined with anterior vitrectomy. Why 6 here? I said 6 and 5, and never proceed with 6 millimeter anterior rexus and a larger posterior rexus. Why? Because if you do so, by time lens epithelial cells will grow from the back surface of the anterior capsule, and sometimes, can you see this is the retracted posterior rexus, and this is the anterior rexus. Secondary cataract may emerge from this point, and here you should go again to clear the visual axis. This is the larger posterior rexus. Anterior vitrectomy, it's very important to proceed with very good anterior vitrectomy. Inadequate vitrectomy like this may cause pupillary block glaucoma, and it's going to be difficult to implant secondary IOL, and it will need synechilysis. And inadequate vitrectomy, sometimes lens epithelial cells may grow over remnants of anterior vitreous face, and sometimes it is extensive like this and needs secondary surgical intervention to clear the visual axis. So, anterior rexus 6 millimeter, posterior rexus 6 millimeter combined with anterior vitrectomy. What's going to happen in the future? This will be a beautiful capsular support. It will be a 5 millimeter because it will contract a little bit. It will be a 5 millimeter capsular support where you can inject a multi-piece secondary IOL in sulcus. The IOL optic is 6 millimeter. So the ideal support is 5 millimeter. This is another case at time of secondary IOL implantation, before and after secondary IOL implantation. Another case with a beautiful 5 millimeter capsular support, injecting the IOL in sulcus. Why do we proceed with polishing of the back surface of the anterior capsule? Is it important? We are going to proceed with a huge anterior and posterior rexus, 6 millimeter combined with anterior vitrectomy. It is important because if we don't polish the back surface of the anterior capsule, the summering ring will be very thick. And if we implant intraocular lens over this thick capsular support, it may push the iris lens diaphragm forward, increasing the incidence of secondary angle closure in the future. And sometimes the summering ring is so thick like this. At time of secondary IOL implantation, we have to open the summering ring to aspirate it, and we have to cut the capsular phimosis and clear the visual axis before secondary IOL implantation, and here before and after secondary IOL implantation. And sometimes, despite having a beautiful clear visual axis, this thick summering ring is very extensive. At time of secondary IOL implantation, it is very thick. We cannot implant directly the IOL, so we have to open it, and we have to aspirate it, and we have to cut the posterior capsule like this, and then we go for secondary IOL implantation in sulcus. And if we don't polish, sometimes the summering ring will burst spontaneously like this, requiring secondary surgical intervention to clear the visual excess. And sometimes the sommering ring may burst even after secondary IOL implantation, causing obstruction of the visual axis, necessitating secondary surgery to clear the visual axis. And look here, this is the site of spontaneous rupture of sommering ring. But when we polish and we have a crystal clear anterior capsule, look what happens at time of secondary IOL implantation. We will have a beautiful thin capsular support where we can inject the IOL in sulcus. Here another case, 6 millimeter rexus, anterior rexus, polishing the back surface of the anterior capsule, 6 millimeter posterior rexus combined with anterior vitrectomy. Let's see, 4 years after surgery, a very thin fibrotic capsular support. Can you see this is the edge of the anterior and posterior rexus? We can inject the IOL in sulcus. Here, years after surgery with a beautiful thin capsular support. Here, years after surgery with thin capsular support and the IOL located in sulcus. And another advantage is that when you have a very thin capsular supports like that, after IOL implantation in sulcus, we can even push the IOL optic behind the capsular support, performing optic capture technique. This is another case with thin fibrotic capsular support after IOL implantation, pushing the IOL optic, proceeding with optic capture technique. This is 2 years after optic capture technique, and here 5 years after surgery, and here 10 years after secondary IOL implantation in sulcus with optic capture technique. This concerning the surgery. Post-operatively, for cases where we did go for cataract surgery without IOL implantation, how to fit them with spectacles. These are the ideal frames. It is silicone frames, and it fits perfectly over the faces of these young babies. It should fit perfectly over the nose. It should cover the eyebrow. It should be like that. And it fits perfectly even in the small faces of these young babies, down babies with small flat nasal bridge. And we use the lenses ultra-thin high definition glasses. This is the difference between the conventional glasses and the high definition glasses. And these are perfect glasses for these babies, especially in babies with more than plus 20 diopters. This is plus 23 diopters, but yet it is acceptable and can be fitted on these small faces of these adorable babies. Here, another babies with above plus 20, and even in preterm babies with congenital cataract, we can fit them with these glasses. And this is a preterm baby after having treated with retinopathy of prematurity and then proceeding with cataract surgery. And here, 3 months after cataract surgery. In older children above the age of 2 years and approaching the age of 3 years, we can fit them with ultra-thin, high-definition, multifocal glasses. These are beautiful glasses, and actually it made me delay the secondary surgical intervention until the age of 4 years. This child is 4 years old. He is coming with the ultra-thin, high-definition, multifocal, and we're going to go for the secondary IOL implantation. Another twin, and then they are 4 years of age with the multifocal ultra-thin glasses, and then we are going to go for the secondary IOL implantation. And they have advantage in unilateral aphakia. We can go for unilateral aphakic spectacles with good amblyopia therapy like that. We can attain straight eyes. Can you see here straight eyes? Here straight eyes with aphakic spectacles. This will make us delay the secondary IOL implantation even in unilateral cases. This is unilateral congenital cataract. Here, immediately after surgery with good amblyopia therapy, attaining straight eyes. Few months after surgery, straight eyes. 1 year after surgery, she came from her country with straight eyes and ready for secondary IOL implantation. This is another baby with unilateral cataract and microphthalmia. Here, after surgery, with good amblyopia therapy together with the aphakic spectacles, attaining straight eyes. Here, a few months after surgery, still maintaining straight eyes. This is a congenital cataract with exotropia. This is less than 6 months, sorry. Immediately after surgery with good amblyopia therapy, attaining straight eyes. 1 year, at age of 1 year, we implanted secondary IOL implantation with straight eyes. Here, 1 year later, straight eyes, 2 years later, straight eyes, 3 years later, still maintaining straight eyes, 4 years later, still maintaining straight eyes. This is an eye few months after surgery with anterior and posterior rexus and IOL implanted inside the capsular bag, and the same eye 20 years after surgery with extensive calcification of the summering ring, but still maintaining clear visual axis. Here, can you see the summering ring and a beautiful clear visual axis? And this is the boy 20 years after surgery, still maintaining straight eyes. For spectacles for bilateral pseudophakia, we fit them with multifocal glasses with a near add of 3 diopters for reading. And actually, I finished my lecture, and finally to conclude, you have to be extensively meticulous and careful when dealing with these young babies, especially those infants where we proceed with the cataract surgery without the IOL implantation in order to see these adorable smiles on the faces of these adorable babies when they are no longer visually handicapped after congenital cataract surgery. And I like to show you this adorable baby from Libya. This is the first time for him to see with the aphakic glasses. I like to document this moment. He's wearing the aphakic glasses for the first time. Beautiful smile, increasing the smile, looking around, more smile, celebrating with one hand, celebrating with both hands, maintaining a beautiful smile, I hope forever, بإذن And thank you very much for your kind attention.
Thank you very much, Dr. Nihal. Barakallahu feek. And we are smiling like that baby, Dr. Abu Bakr.
أي شكرا جزيلا دكتورة نهال الحقيقة very very interesting lecture. أنا شخصيا استفدت من بعض التبس فشكرا لك والله. أنا بعد شوفوا أذن الزملاء إذا كان حد عنده سؤال. أنا عندي حتى سؤالين.
تفضل دكتور.
Okay. نبي نسأل دكتورة نهال if do you ever implanted an IOL in microphthalmic eye like الcases بتاع persistent fetal vasculature يعني.
Yes, I implant a microphthalmic eye, but if I have a corneal diameter 10 millimeter, not less than 10 millimeter. But
Okay.
implant with an axial length with an أصل microphthalmic eye ممكن normal anterior segment and normal corneal diameter. These no problem. I can implant up to 40 diopters intraocular lens, no problem. The problem is with small anterior segment. I should not implant if I have a corneal diameter less than 10 millimeter.
Do you recommend a special kind of lenses in microphthalmic eyes?
No, I still implant the Acrysof intraocular lens. In the past, Acrysof lenses used to produce small lenses, 5.5 millimeter diameter. It was beautiful, but they stopped their production.
Okay. My second question هو ال percentage of high intraocular pressure post surgery in your cases. هل هو high ولا زي ما موجود في literature ولا less or And what do you do to minimize this kind of complications or late complications?
Secondary glaucoma is inevitable. It is inherited, actually. It may occur a few months after surgery, years after surgery. We have cases between me and Professor Nader that developed glaucoma 10 years and 14 years after surgery.
Okay.
To follow up your cases for life. The incidence is not that high. It is less than 4% in our case, but
very
still,
good. Very good.
yeah, but still it occurs. It occurs in cases, very straightforward cases. الcases يعني دول بيبقوا genetically susceptible to have this glaucoma. إنما طبعا الإياثروجينيك glaucoma لما يبقى فيه bad surgery, definitely the incidence gonna be high.
أنا بناخذ رأيك في حالة حقيقية specifically، يعني عندي الأسبوع هذا موجودة حاليا وما زال أنا hesitating إني implant an IOL. هي كانت persistent facial vasculature. عملنا الكاتاراكت، كانت الاي سمول، كان تقريبا 9 ملم corneal diameter. بعد العملية كانت كويسة إلى حد ما، لكن لاحظت أن فيه ازدياد سريع شوية في حجم العين، والكورنيا ما طمنتنيش. خذيتها اي او اي، لقيت الاي او بي عالي شوية، يعني كان ممكن في 25 26. والأهل مصرين على موضوع السكندري امبلانتيشن بتاع الاي او ال، لان لما طبعا شافوا العين كبرت شويه هم فرحوا، ما حسبوش انه كومبليكيشنز جيتو هاي اي او بي، فمصرين. فانا متردد، يعني انا حطيت انتوا على انتي جلوكوما تريتمنتس، ومفكر ان نفكروا في عمليه الجلوكوما اللي صارت. فدي ريكومند الجلوكوما وبعدين secondary implantation، ولا جلوكوما بعدين contact lenses؟ what do you recommend?
Number one, I don't prefer secondary IOL implantation in this case. It is a persistent fetal vasculature. هل فيها prominence of ciliary processes أو لا؟
لا، تو حاليا لا.
ما كانش في وقت السيرجري. It was a straightforward case. The glaucoma
كان بسيط يعني، لكن هي definitely persistent fetal vasculature، لكن ما كانش زي ما تقولي very aggressive وفيها زي ما تقولي prominent blood vessels وكذا يعني.
I don't recommend. Corneal diameter قد إيه؟
دلوقتي 10.5 تقريبا.
دلوقتي but before, definitely a time of surgery, if it was
لا، كان
less,
صغير جدا، 9 كان تقريبا.
I don't recommend.
Okay.
إلا بس you have to know whether this glaucoma يعني هل في سبب ولا لا. يعني مثلا is there a posterior synecha? Is there a peripheral anterior synecha? Is there an iris to the wound? Is there a pupillary block from vitreous in the anterior chamber? If there is no cause from the primary surgery, خلاص you will proceed with the glaucoma surgery sooner or later. But if there a cause, يعني for example لقينا total posterior synecha, لا, we have to go first in order to clear the visual axis and to relieve the synecha first. ده في حد ذاته ممكن to lower the intraocular pressure.
هي حاليا ما عندهاش صينيكيا ولا حاجة، وحتى شفت أنا in details I examined her under EUA under anesthesia، ولما قست الضغط كانت الانتيريور سيجمنت كويسة، ما فيش سبب معين عرفتي يعني anatomically، يعني باين علي أنه هو ممكن اللي مسبب ارتفاع في الضغط.
It's better to start medical treatment if not glaucoma surgery and not intraocular lens implantation.
Okay, very good. Thank you so much. عبد الباري، شوف حد من الزملاء لو عنده سؤال في الرسائل ولا حاجة.
كاتبنا الأفاضل يتفضل بأي سؤال أو مداخلة. تفضل.
في سؤال من الدكتور هاني، لو تشوفه في المجموعة.
Do you prefer 3-piece IOL? What's 3-piece IOL you prefer? Or من 2 to 4 years?
from 2 to 4 years old. From 2 to 4 years old, if it is a straightforward cataract surgery, you proceed, as I showed you, anterior rectus 5 millimeter, posterior rectus 4 millimeter, anterior vitrectomy. The injection of the single piece is much more easy than the multi-piece. If you master the multi-piece, it's not a big deal. يعني لو احنا straightforward surgery ممكن استخدم single piece or a multi-piece. For me, it is much more easy it's single. لكن في sometimes cases you should implant a multi-piece. امتى؟ مثلا if I'm gonna implant in sulcus. طب امتى implant in sulcus؟ ولنفرض you don't have a posterior capsule, it is torn, a large posterior rexus. ما بقاش عندنا غير الانتيريور capsule rexus 5 ملم. هنحط in sulcus؟ ينفع نحط in sulcus a single piece؟ Never. It has to be a multi-piece. فالمالتي بيس لو احنا هنزرع in sulcus سواء secondary IOL implantation أو primary IOL implantation in the sulcus, it has to be a multi-piece. إنما لو primary surgery between the anterior and posterior rexus, you can inject أيا منهم.
في سؤال آخر دكتور محمد زين do you do bilateral simultaneous surgery or in sequence؟
routinely لازم تبقى never I perform at the same time إلا في حالات نادرة جدا. sometimes when I have مثلا حالات cardiac في عندي حالة مثلا laryngomalaysia وهتطلع الانتراكيوماليشيا وهتطلع تروح الانتنسيف كير في ريسك كبير عليها فبضطر في حالات قليلة جدا جدا if the systemic condition needs this. And I'm gonna need an intensive care after the surgery. I did it maybe 4 or 5 times. لكن never to proceed with simultaneous. ليه؟ لأن ولنفرض حصل أي حاجة، ولنفرض حصل endophthalmitis، يعني الحمد لله ما فيش، لكن for children you have to be very cautious. I prefer to go for one eye and then wait for a few days and then I go for the other eye.
أي حد من
Okay, I have
الزملاء؟
another question. I have another
تفضل.
question. يعني your advice لو أن I operated on a congenital cataract case when she or he was مثلا 2 months old. أمتى تحبي لو أن الوقت معك أمتى تحبي تديري secondary implantation؟
أولاً أنا I don't like to operate as early as 1.5 as it is written in books. You have to proceed with the unilateral cases before 6 weeks علشان البinocularity. Let us weigh binocularity and amblyopia ولا secondary glaucoma. لازم ناخد أخف الضررين بمعنى إن the lower I go beyond the 3 months of age, younger than 3 months of age, I'm increasing the incidence of secondary glaucoma. I prefer to go for the cataract surgery, bilateral or even unilateral, after the age of 2.5 months. يعني بخلي البيبي يجي عند شهرين وابتدي أدي الميعاد. And sometimes I defer the surgery to 3 months of age if the cataract is not dense. فما بين 2.5 ل3. This is number 1. طيب لو unilateral, I did the cataract surgery at the age of 2.5 months. When to implant? In the past few years, I used to implant at the age of 6 months. Why? Why not يعني أقل من 6 months? لأن إحنا عندنا curvature of the cornea changes massively in the first 6 months of life. If I implant below the age of 6 months, myopic shift will occur within few months and you will have to change the intraocular lens. تاني حاجة، طب ليه عند 6 شهور خلاص احنا عرفنا. الأكزيا length 80% of the axia length occurs in the first 2 years of life. عشان كده bilateral we defer after the age of 2 years. But unilateral بنزرع. Recently أنا ما بقيتش أعمل 6 months. ما بقيتش أزرع عند 6 شهور، بقيت أجل لسنة. ليه؟ زي ما وريت حضراتكم، بقيت أستخدم الunilateral aphakic ultra thin glasses. These are very expensive glasses. quality of vision is more than perfect. ما فيهاش كل disadvantage بتاعة الانايزوكونيا بتاعة conventional aphakic glasses. وزي ما وريتكم eyes مع good patching remained straight until the age of 1 year, and then I implant now the secondary IOL. إنما كل السنين اللي فاتت كنت I used to implant at the age of 6 months.
ولا دكتورة بعد إذنك لو تبعثي لنا البراند هذا أو الشركة اللي بتعمل في الألترا ثين هايبروبيك جلاسز عشان نوصل الأوبتيكال شوبس اللي عندنا بيجيبوها يعني.
لأن برضو هم كان طلبوا مني في السعودية ووصلتهم بالمصنع ده، مصنع مصري هو اللي بيصنعها، وهو كان بيصنع لأنه بيتعاون معايا على مدار آخر 20 سنة بيعمل لي
مهم.
الجلد. فهو اللي جاب التكنولوجي دي مخصوص to our patients.
very good والله.
لما جربناها بصراحة it is outstanding، وخلتني كمان أأجل السكندري IOL implantation. I used to implant at the age of 2 years secondary IOL. دلوقتي I deferred it to 4 years. فخلاص التوبيك شيفت قل كتير عندنا. الحاجة التانية إنه التكنولوجي اللي دخلها الجميلة إنها البايلاترال أفيكيك جلاسز عند الطفل لما بيروح حضانة عند 3 سنين ابتدى يعمل لي مالتي فوكال. فالطفل
very good.
كمان الكالورينج والرايتنج، ف it is really outstanding glasses. إن شاء الله أبعت لكم اسم المهندس صاحب المصنع،
كويس.
تقدروا تتواصلوا معاه. وهو ابتدى كمان دلوقتي يبعت النظارات دي اونلاين. يعني
very good.
قوي ان في اطفال افاكك في in Saudi Arabia he did send them the glasses. يعني نفسي ان كل الاطفال في الدنيا تستفيد.
والطفل حيستفيد منها كأنه لابس كونتاكت لينس، يعني قضية الأنيزيكونيا هذه ما هيش مشكلة.
يعني not to that extent طبعا.
ها
يعني ideal is contact lens, but let us يعني think practical. Contact lens is not actually a good choice, at least in my patients. احنا الweather very hot، في humidity مع cleanliness. يعني شفت زمان when I used to try it first corneal abscess مش ما هياش actually practical in our children. بتقع هيعوز يغيرها كتير. يعني it is not an ideal choice, at least in our children. Maybe in Europe, maybe elsewhere it is the best choice, but at least it is not appropriate in in my
هي
country.
بس نقصدي على الادفانتج بتاعها على الريجولار هايبروبيك لينسز، هل هي بس لأنها ثين ولا في اوبتيكال ادفانتج I mean؟
There are optical advantages وإن شاء الله بإذن الله يعني بحاول إن أنا أجمع كل الداتا علشان تبقى الأرقام more scientific يعني. إنما that what actually I saw clinically، لأن هي دي الحاجة available اللي قدامي. ف I've tried it. I found it إن يعني أنا بقالي دلوقتي كذا سنة بجربها. فالأطفال بتقبل الأيفاكيك مالتي فوكال، مع إن في أطفال كبار شوية مش بيقدروا يستحملوها. يعني الكبار ممكن لو مثلا اكتوبيا لانتس وما عنديش ايرس كلولانز ومارفان ومش هقدر ازرع، ساعات I fit them with aphakic glasses multifocal or bifocal glasses recently حتى كبار.
والله نشكرك جزيلا دكتورة، بصراحة احنا كانت المحاضرة قيمة جدا واستفدنا منك، وشكرا جزيلا على منحك هذا الوقت. بارك الله
آه،
فيك.
دكتور، عندك وقت ثاني لأسئلة أخرى؟ دكتورة.
اه طبعا، اه طبعا شور. احنا في رمضان
هل
ما
مشكورة
فيش
جدا. هل تزرعي
شور.
مالتي فوكال اي او ال؟
لا and I'm not convinced and I will not try it. يعني at least في الأطفال، لأن أنا بشتغل infants و children. maybe يعني الأطفال اللي هم approaching adulthood ممكن يعني، لكن I never used. I have no experience in it. If one day I'm gonna try it will not be less than 13 or 14 years of age. يعني I'm not
What?
convinced.
What about hydrophilic?
Hydrophilic, I used to implant hydrophilic in the past. It is good, بس ال aggression of the secondary cataract around the intraocular lens is severe. لأن أنا بتابع حالات. أنا أول بيبي عملته هو عمره دلوقتي 32 سنة. وأنا بتابع البيبيز بتوعي along the years. يعني انتوا شفتوا، أنا فرجتكم بعد حالات قد إيه البيرلز السيفير حوالين الانتراocular لينز. وسometimes بنلاقي السومرينج رينج بتفتح زي ما وريت لكم حتى بعد السكندري ايول امبلانتيشن. وسometimes it burst into the vitreous. انا بتكلم ده سنين، 10 سنين و15 سنة بعد الجراحة، عشان احنا عندنا يعني ريكورد كبير من الأطفال. فأنا بالنسبة لي I don't recommend الهيدروفيليك now. يعني
Yes.
I prefer. طيب في عدسات تانية كويسة. طبعا في كويسة، بس they are not appropriate في الأطفال. ليه؟ يعني أنا مش عاوزة منشن طبعا
شركات.
عدسات الشركات. أنا ما بحبش أعمل لا دعاية ولا against ولا with. إنما لما I used to see حالات مثلا جايه لي فور IOL exchange، حد عمل سيرجري كويسه جدا والطفل كبر وبعدين عاوز يعمل IOL exchange، فباجي اطلع العدسات دي. they are extensively thick. they cannot be يعني actually rotated easily and got outside the capsular bag. عندي محاضرة على ال IOL exchange فيها كل ده، ان احنا we should not ever use التايبس بتاعت الانتراocular lens، عشان لأي سبب لو حصل myopic shift and I need to go for IOL exchange تطلع بمنتهى السهولة زي ما وريت لكم، وتبقى implanted واحدة تانية بمنتهى السهولة.
طيب when you do polishing for anterior capsule, your target is to remove all the cells or remain some cells.
هو المفروض يبقى crystal clear as much as possible. عشان كده a good visualization is very important. If you cannot see the anterior capsule, if you don't have a good magnification, if you don't have a good microscope, if you don't have an excellent red reflex, you will not be able to do these things. يعني الحاجات دي مش بتعتمد بس على الدكتور، لا، بتعتمد على الفاسيلتيز كمان اللي موجودة.
Yes.
الحاجة الثانية ان ما ينفعش conventional irrigation aspiration كانيولا اللي بتستخدموها for adults اللي هي السموث. في كانيولا مخصوص ممكن ابعت لكم اسمها والرقم بتاعها. هي جايدر، عندها التب بتاعها رف،
Okay, yes.
فدي بتعمل an ideal polishing of the back surface of the anterior capsule and sometimes the posterior capsule when you have remnants of cortex on it. It's a beautiful IA، مش ال conventional IA اللي كل الناس بتستخدمها في الفيكو surgery.
The mechanical suction
عندي
at the same time.
aspiration.
طبعا عندي كومنت على الاي او ال عبد الباري وحضور الدكتوره. انا بديت حاليا في الايدوف الاكستندد ديبث اوف فوكس، وهي هيدروفوبيك ات ذا سيم تايم. على الاقل أنا لما قريت عليها شويه هي ليست اوف اوبريشن، وبالنسبه للكونتراست سنسيتيفيتي قاعد يقولوا افضل في الدراسات وكذا. اتشجعت شويه، بديت في الاطفال. ان الميزه بتاعها ان هي حتى هي ثين وفي نفس الوقت ستيل هيدروفوبيك. ويعني صفة الاكستندد ديبث فوكس قلت لعل وعسى ممكن تفيد شوية الطفل، والله أعلم. بنشوفه عاد بعد السنين الجاية، نشوفه شنو يصير معنا نقارنه.
إن شاء الله. في برضه دكتور قديح، I think دكتور قديح بيقول كومنت.
السلام عليكم.
عليكم السلام. عليك كيف حالك؟
Dr. Nihal, thank you very much. This was very informative session. I enjoyed it very much. I have two questions. One of them, do you use iris fixated IOLs? Do you think there's a role for those in this age?
Definitely, I implanted many cases of iris claw lens, but not in congenital cataract, of course. I implant iris claw lens when I don't have a capsular support. I used to implant it in cases of ectopia lenses, and of course not Marfan, because Marfan, they have a high incidence of retinal detachment. I used to implant it in ectopia lenses, those straightforward cases not associated with systemic disease as Marfan. I used to implant it in the posterior chamber and in the anterior chamber. I used the Artisan intraocular lens. I've been using it for the past 18 years. Until suddenly, and all of a sudden like that, Optic stopped production of the Artisan IOL. I'm really so sad because it was a perfect IOL and I have perfect results along these 18 years. I used to go for specular microscopy to all my patients every 6 months. And actually it did stand the time. The first intraocular lens that was implanted 18 years ago, and I still have crystal clear cornea. The conclusion is that children are liable to trauma, to eye trauma. Those implanted in the anterior chamber, this inclavation occurred, and I did re-inclavation again. It was not a big deal. Those implanted in the posterior chamber, they are wonderful, but with severe eye trauma, and children are liable to have eye trauma or head trauma in school or something like that, posterior disinclavation and posterior dislocation into the posterior segment is not something good, because you're going to refer to a posterior segment surgery and it's going to be a posterior segment surgery. So now I prefer to implant in the anterior chamber unless I have a contraindication to be implanted. I used to implant it in traumatic cataract where I don't have a capsular support. For example, the lens is totally torn. I don't have an anterior capsule. I don't have a posterior capsule. I implanted in traumatic cataract also. So actually, it's a beautiful lens.
Thank you very much. The second question about lenses that severely malformed, like when you have a lens that's just a fibrovascular tissue, and when you go in to remove the cataract, there is no cataract, there's actually just a fibrous membrane that you try to remove. What's your approach to this with the severe anterior segment dysgenesis?
You mean persistent fetal vasculature with extensive fibrosis?
Correct. Yeah.
Okay. Do you have time?
Yes, we do.
I will show you just
Yes, we do.
a photo, okay? أنا مش عارفة أجيب البرزنتيشن بس كان نفسي أجيبها.
انت عملتي شير سكرين بس الواتساب.
You mean cases like this?
We cannot see دكتورة. We are seeing your WhatsApp now, not window of WhatsApp. يمكن تعملي stop sharing و sharing again.
أعمل شير تاني؟
شير تاني شير للبرزنتيشن اللي انت عايزه. هو بالنسبة أيوه تمام كويس حلو. هذه تقصدها دكتور بديح؟
هل ده اللي حضرتك بتقصده؟
Is this what basically I mean is that the lens becomes a fibrovascular membrane like this, yeah, with blood vessels.
Like this?
This looks like a post surgery. It happened after.
No. These are
A primary case?
resistant
Yes.
fetal vaccine.
Yeah,
These
exactly.
are all lenses.
Yes, exactly. No, the previous slide was. Yeah, this is what I mean. These kind of membranes, they are very resistant to, you can't do a capsulorhexis on these. You have to do it with a retractor.
Definitely.
But, yes.
These cases, I will show you. These cases?
Yes, exactly. Yeah.
هو مصداقية لكلام الدكتور بديح. دكتورة ثالث حالة congenital cataract I do like this. I do ultrasound. There is no stock of persistent fetal vasculature. When I remove the cataract I shook by feature or vascularized fibrosis in the posterior part. يعني يمكن persistent fetal vasculature we cannot find the stock in the ultrasound, but we facing picture like this. I really stop the patient and transfer, after I remove the cataract, I transfer the patient to vitreoretinal surgery to remove the posterior capsule. What's your opinion? Yeah, when I see the VR do the surgery as simple, I thought I can do it simply, not very hard. I was afraid from bleeding. I was afraid from bleeding. Really.
ممكن بعد كده أعمل لكم talk على persistent fetal vasculature أنواعها and how to and manage the posterior capsule في الحالات اللي فيها vascularity جامد.
Yeah, that would be great. And also, how do you manage them? How do you manage the refraction after? Like how do you base the glasses prescription on what? These are very hard to refract, and especially microphthalmic eyes. What? How high you can go with the glasses, and how you?
I use autoref, handheld autoref, either without anesthesia or sometimes I use general anesthesia to go for refraction. It's not difficult. What difficult about refraction?
Well, the case I'm particularly interested in is a case that we faced last week. Was about 6 millimeter microcornea. Yeah, and it was severely malformed, but with the retina look like it's in a flat retina on the ultrasound, but it was very malformed. The lens was almost like a small vascular tissue, fibrovascular tissue right in the middle. We had to perform like a eccentric iridectomy to open the visual axis, but I don't know how to fit them with glasses after.
I tell you something. This is one type. This is microphthalmia, and probably if you had a flat cornea and you didn't have the stock of hyaloid artery, this is called posterior fibrovascular sheath of the lens. It is one type of persistent fetal vasculature. It is persistent of what? Posterior tunica vasculosa lentis. Okay? It appears like that. Together with microphthalmia. How to proceed in these cases? Number one, you need a central clear visual axis. If the pupil is distorted or downward displaced or ectopic for any reason, you should go for multiple sphincterotomies. At the end, you want to have a central pupil. And then you go for this fibrovascular membrane or whatever by an MVR knife. You penetrate this membrane because it will not be ever cut. by the cutter. You penetrate it with the MVR and a micro scissors. You should have a 25 gauge. I use the conventional 23, but in microphthalmic eyes, I use 25 gauge scissors. You cut, you make sort of several cuts, and then you trim with a 25 gauge cutter. Otherwise, it will be very difficult to proceed with surgery. And in these cases, I have also MVR knife. The knife is 0.6 millimeter. It's not 0.7. It's not 0.9, not the conventional 20 gauge. These knives are also custom made from goiter. They're specially designed for small eyes.
Mm-hmm. Yeah, very interesting. Yeah, thank you very much. Yeah.
دكتورة في أسئلة من التشات. What's your preferred approach in cases of uveitic cataract? I don't know, maybe uveitic child.
Yes, uveitis. Uveitis, number one, they have to be controlled from uveitis with a uveitis specialist. يعني I proceed with surgery, but before surgery, at least 3 months totally free from uveitis. طبعا definitely you should know the etiology. We will not proceed with a cataract surgery without knowing the etiology. And in some cases, like مثلا, for example, juvenile rheumatoid arthritis, it is claimed contraindication to implant intraocular lens. I don't implant if the cataract is bilateral. But sometimes if it is unilateral, I implant intraocular lens. Pre-operative steroids يبقى الأول هيبقى controlled لمدة 3 شهور. Pre-operative steroids بالuveitis specialist. Post-operative systemic steroids برضو تكون tapered with a uveitis specialist. And in these cases بقى how to proceed. Number one, you have to perform anterior rexus. غالبا بيبقى فيه membranes in front of the lens. You peel it off. Sometimes some cases referred على إنها uveitic cataract, and it is actually epilenticular membrane, fibrotic membrane. So don't dip directly into the lens. With the microrexes, try to peel this membrane first. في حالات كتيرة لقيتها وراها اللينس crystal clear. فدي أول حاجة نخلي بالنا منها. تاني حاجة, if it is really complicated cataract, we have to go meticulously for anterior rexus حتى لو في fibrosis في anterior capsule أو posterior capsule. Posterior rexus, very good anterior vitrectomy. المشكلة هنا in the anterior vitrectomy, usually it is liquefied vitreous. اللي هي عاملة بيطلع كتير في الانتيريور chamber. We go with the anterior vitrectomy without the irrigation first. نعمل very good anterior vitrectomy without hydration of the vitreous and then introduce the irrigating cannula. After this, it's a must to implant the IOL inside the capsular bag. If you lose the capsular bag for any reason, never implant in sulcus. Never implant in sulcus.
You mean implant Yemeni technique?
Never. Uveitis never. يبقى you will not implant. عشان يحصل لك intractable inflammation and the IOL will be cocooned in fibrosis after surgery and it may end into atrophy bulbar. Take care of uveitis cases. They are surgery سهلة, لكن post operative inflammation بتاعهم ممكن يبقى severe.
Angry eyes لو زعلت مشكلة.
يزعلوا قوي. الحاجة التانية إن subtenon or subconjunctival مش short acting زي الأطفال. لا, long acting steroids تتحقن subtenon or subconjunctival.
Other question about how you visualize posterior capsule, or how you can separate between anterior and posterior. Is it easy or not?
It is easy. As I told you, you go with the tip of the cystotome. في برضو حاجة مهمة جدا. دلوقتي I finished irrigation aspiration. and I want to do posterior access. When you come to inject the viscoelastic, don't fill the capsular bag with viscoelastic. لا. Inject at the level of the iris. Make the iris, the anterior capsule, the posterior capsule, all in one plane. يبقوا كلهم على خط واحد كده. ليه؟ لأن احنا if we inject viscoelastic كتير and we filled the capsular bag, the posterior capsule will be displaced posteriorly. مش هنعرف نعمل posterior capsular access. فلازم كلهم يبقوا in one plane. And then we introduce the cystotome, and by the cystotome مش ندخل perpendicular when dip into the anterior capsule. لا. بنخلي الcystotome parallel or tangential to the posterior capsule, and then we hook it. Once بنلمسه كده بيبان. هم شكلهم السؤال ده شكلهم مش شافوش المحاضرة، مش عارف هي ما كانتش واضحة يعني.
لا، في بعض الدكاترة فعلا التحقوا حاليا، لكن على العموم المحاضرة ريكوردد وراح يس.
يعني مجرد ان هم بس they elevate the posterior capsule هيشدوه hooking وتانتنج وتيرنج. it can be easily. وزي ما قلنا الانجكشن ازاي في البرجر سبيس ما ندخلش الكانيولا inside the tear، بعيد، من بعيد بنقوم injecting على الادج of the posterior tear اللي احنا عاملينه، وهتعمل الهيلو المدورة اللي احنا شفناها دي.
هو يمكن
كده
حتى سؤال يمكن دكتورة هاو تو سيبريت في السكندري في الاي ويل امبلانتيشن، في السكندري اي ويل امبلانتيشن يمكن سؤال
yes
اوضح. هل easy to separate في الانتيرو كبسول from the posterior capsule in the to implant
in the
secondary IOL?
secondary.
Yes.
In rare circumstances we can separate them, بس I don't want them to be separated. I told you I polish perfectly the lens epithelial cells عشان يبقوا زي الممبرين. I don't want to separate them. هيبقوا thin membrane. I implant the secondary IOL over them in
Yes.
sulcus.
I think the last question about what are the most important points that we must take into consideration when we choosing the lens with an appropriate power for the children. She mean the power of IOL implantation.
The
What the rule
yes.
you choose?
You mean the power of the lens?
Yes.
Concerning the power, in literature مكتوب in below 2 years of age under correction by 20%. Above 2 years of age 10%. وبعد كده we can go for emmetropia at the age of 4 or 5 years. I don't do this. Why? لأن if I undercorrect 20%, this will be مثلا ممكن توصل 6 diopters 10 diopters, which is يعني inappropriate بالنسبة لنا إننا to fit them with the glasses. وخصوصا إن sometimes الأطفال ممكن ما تبقاش يعني متعاونة في موضوع الجلاسز والparents، فأنا ما بحبش أعمل الماسيف under correction. I prefer to go for under correction below the age of 2 years 4 diopters, depending upon the refraction of the fellow eye. ولنفرض الريفراكشن الناحية التانية plus 5، لا أقدر أنزل أكتر من 4 diopters. طب ولنفرض إن الريفراكشن in the fellow eye أو النورمال eye myopic، يبقى أنا ما أقدرش أنزل ل4 و5 diopters، يبقى هعمل under correction أقل 2 diopters. يبقى لازم ما يكونش فيه anisometropia more than 4 diopters between both eyes. This is number 1. Above the age of 2 years, I go for emmetropia. ليه؟ لأن حتى لو they develop myopia, it's not a big deal. I can go for IOL exchange easily. If I go for a beautiful surgery, an appropriate intraocular lens inside the capsular bag, and this suitable IOL, which I told you about, I can easily rotate it and get it outside the capsular bag and go for IOL exchange. يبقى below 2 years of age and under correction 4 diopters بالكتير ما بين العينتين Above 2 years of age, I go for emetropia. This is my routine, my personal routine.
Mhm. With this routine, you do not find that you increase the rate of ion exchange in future.
لو أنا بزرع primary at the age of
Mhm.
2 years،
Yes.
مثلا عندي bilateral congenital cataract عمره 2.5 أو 3، I aim for emetropia. الاتنين مع بعض will develop myopic shift. It's not a big
Mhm.
deal.
Mhm.
If unilateral هيحصل myopic shift، هيحصل myopic shift. I go for ion exchange. It is very simple and easy to perform as long as you did a good primary surgery.
Yes. Yes. Thank you very much دكتورة. كان very interesting. والصراحة الكل تشوق للقاء آخر إن شاء الله.
إن شاء الله.
إن
إن
شاء
شاء
الله.
الله.
فراح نشوف إذا كان في إمكانية في رمضان أو حتى بعد العيد يمكن تكون معنا دكتور.
إن شاء الله، ما أنا هاجي طرابلس آخر ماي.
إن شاء الله بإذن الله.
ناس
آه.
تنسي وتشرف يا دكتورة، لكن الجماعة طمعين حتى في ميتنج قبل
سيشنز.
حتى جيتك لطرابلس إن شاء الله.
في أي وقت ممكن بعد صلاة الجمعة، في أي وقت سواء رمضان أو بعد رمضان، يعني أي series of lectures، أي حاجة عاوزينها، persistent fetal vasculature، microphthalmia، trauma، أي حاجة يعني. So welcome. أنا I believe in before I leave this world أتمنى من الله سبحانه وتعالى أكون من الناس اللي هم إذا مات ابن آدم انقطع عمله إلا من 3: صدقة جارية، العيانين، علم ينتفع به، المحاضرات دي، وولد صالح يدعو له. فأنا اللي ببقى willing to spread any knowledge. لو أي حد استفاد ولو كلمة واحدة، أنا اللي هبقى محظوظة عشان أخدها علم
جزاك
ينتفع
الله
به.
خير،
فعلا بارك
شكرا
الله
شكرا
فيك وإن
جزيلا،
شاء الله في
بارك الله
ميزان
فيك.
حسناتك. فعاوزين كل المحاضرات اللي قلتها مش واحدة بس. إن
إن
شاء
شاء
الله.
الله بإذن الله نتفق
شكرا
على.
جزيلا.
شكرا.
حاضر خلص.
عفوا، شكرا لله.
أشوفكم على
شكرا يا
خير.
عبد الباري على إدارة الحلقة، صحيت،
بارك الله
شكرا.
فيكم جميعا. وراح ننزل إذا
أتمنى،
كان
شكرا
في أي
جزيلا.
إعلان نبلغكم جميعا إن شاء الله. بارك الله فيكم
إن
جميعا
شاء الله أنت
دكاترة
طيب.
الأعفاضل.
عايست.
وإن شاء الله صياما مقبولا وإفطارا شهيا دكاترتنا جميعا إن شاء الله.
أجمعين أجمعين إن شاء الله، في أمان الله.
السلام عليكم.